Great. All right. So on my clock, it is exactly 7 o'clock Eastern time. I will just close this so that you can see me a little better. Welcome everyone this evening to our presentation. I'm very pleased to have Sheri Van Dijk with us again to speak further about some of the DBT concepts that we as families can use to help understand better our youth with issues around self-harm. Before I get to that, I just want to introduce myself. I'm Doreen Heineman. I'm the program manager for the Sashbear Foundation, and I'm joined today as well by Barb, one of our volunteers who will be helping me behind the scenes with the chat and the Q&A. I want to let you all know that this is being presented as a webinar. And what that means is that you are all automatically hidden. We can't see you. We can't hear you. So you don't need to be worried about interrupting or causing any disruption. You can play with your dog. You can eat your dinner. You can get up and move around, and none of that will bother us or any of the other members who are attending today. This is being brought to you by the Sashbear Foundation. And I just want to briefly let you know about the Sashbear Foundation. We work throughout Canada to provide information and advocacy around issues of emotion dysregulation and suicide prevention. And particularly, we offer the Family Connections program, this series of expert educational presentations by experts in the field. And we're involved in a number of other activities. I want to let you know, just as a sort of heads up, that one of our big annual events is coming up, and that is our Sashbear Walk, which happens every year in the spring. And so I just want to very quickly let you know that what we have happening for this year is really exciting because the pandemic appears to be improving. And so we have now scheduled 4 different locations for an in-person gathering in British Columbia, Ontario, in the province of Quebec, and in Edmonton, Alberta. You can see the dates on your screen there. This is an opportunity for family members and supporters to get together, to meet other people, maybe to reconnect with people you may have met through one of our programs or one of our groups. It also doubles as a fundraising effort. Before I mention that, if you're not close to an in-person location, we will also be having virtual involvement. So last couple of years, we had a virtual presentation. This year, we'll be doing some live streaming, and you can be involved in lots of different activities along the way throughout the month of May. Here's the fundraising piece. These are our goals for this year, and lots more information will be provided to you throughout the next couple months. These are some of the different ways that you might want to become involved, either volunteering to help us out, make a donation, start a team to do some fundraising, help us find sponsors, or promote the event. So the actual registration for this event will start the 1st of April, and we run all of our activities through the month of May. So please look at our website. If you're in a group right now, or if you're already on our mailing list, you will be receiving more information about it. So thank you again. Now, I just want to reintroduce and thank and welcome again Sheri Van Dijk for joining us today. She is here again to talk about the issue of self-harm. We had a great response to her first presentation and many, many questions which we couldn't get to answering. So she's very graciously agreed to come back today and address some of those questions and give us some more of her insights. So thank you very much, Sheri, for being with us again today.
It's my pleasure. Thank you, Doreen. So I wanted to preface this by saying, so building on what Doreen was just saying, this is a webinar that I just threw some slides together based on the questions really that came out of the last webinar. So some of the questions were, asking for more information about some of the skills that I talked about. So I'll be building on some of the stuff that we looked at last session. And then just, there might be some random slides thrown in with some information that I just, people had requested. So it'll be a little scattered, but hopefully will be mostly coherent. I also wanted to just really emphasize, because I know many of the questions from last time were around what do I do with my teen when this happens? And I wanted to just kind of remind you, I don't have all of the answers. I mean, nobody has all of the answers, and the information that I'm providing is general information for you to be thinking about, but understanding, of course, that my dialectical answer with all of those questions is going to be, it depends, right? It depends on your relationship with your child. It depends on if they are asking for help. It depends on who you have supporting you in your life and if they're seeing a therapist. So, you know, just I want to validate, it's a scary thing when you find out that your child, that your teen, whoever is self-harming or even having thoughts like that. And of course, I understand, of course, where those questions come from. And I don't have the, you know, the magic wand or the magic answer for it. And having said that, I do have lots of ideas and concepts for you to consider, you know, what might make sense for you given the circumstances that you're dealing with. So just keeping that in mind, I'm going to open up the slides and we'll get going. All right. There we go. And we didn't, I think Doreen was the one who said, so this is the title we have, Helping Youth Who Self-Harm Part 2. And I said, well, I'm not really much more creative, so that's what we're going to stick with, because it's really still what this is about, is helping youth who self-harm. So basically, we're just looking at more skills. So let's get right into this. So there have been some questions around borderline personality disorder and also other diagnoses that might be associated with self-harm, or that self-harm might be associated with. And so I just wanted to clarify that, yes, of course, self-harm is listed as a possible, as one diagnostic criteria for borderline personality disorder. And again, sorry guys, if you weren't here for the last webinar, the NSSI stands for non-suicidal self-injury, which I use interchangeably with self-harm. So NSSI is listed as a diagnostic criteria for BPD. But not everybody with BPD self-harms, and individuals without BPD will also self-harm. Self-harming behaviors have also been documented in a wide range of other disorders, such as, and somebody had asked about this, post-traumatic stress disorder, dissociative disorders. That would include DID, stands for dissociative identity disorder. Also disorders like conduct disorder, obsessive compulsive disorder, intermittent explosive disorder, anxiety and mood disorders, including bipolar disorder, substance use disorders, and bulimia, and probably other eating disorders as well, but I didn't have the research handy for that. So in other words, this happens a lot regardless of diagnosis. And a new diagnosis actually has even been suggested. The DSM, or the Diagnostic and Statistical Manual, which is kind of the psychiatrist's Bible for diagnosing, in 2015, I believe, was when the last DSM was published. And in the DSM-5, it was suggested that perhaps we even need a new diagnosis. That has been suggested as non-suicidal self-injury disorder, because some people don't fit criteria for any other specific disorders, and yet they self-harm. So just to kind of, you know, emphasize the broadness of this problematic behavior. Also to understand that non-suicidal self-injury, of course, is not a new behavior, but it really was not well studied before the early 2000s. And so since the 2000s, we've been collecting more data on this behavior. And since that time, the statistics around it, the information around it, has remained relatively unchanged. So I am just going to talk a little bit about statistics here. You know, hopefully they'll be of interest to you, but also to validate, again, that this isn't an altogether uncommon experience, unfortunately, right? But just to kind of, unfortunately, again, sort of normalize this behavior to an extent. And I don't mean that in the way that, you know, that it's okay that our youth are doing this, but that it's not an unusual thing for them to experiment with sometimes. So it is fairly typical that that the non-suicidal self-injury starts in kind of young teens, so 12 to 14-year-olds. And typically, though, it does decrease in late adolescence. What we do see, though, is that because it's very connected to emotion dysregulation problems, and this becomes a means of managing emotions for that youth who continues to self-harm, if they do leave that behavior behind or start to reduce it, they often will replace it with other problematic emotion regulation strategies, like substance use. So one recent study found that adolescents who had stopped the repetitive self-harming behaviors were more likely to show higher levels of substance misuse. So they've kind of traded one problematic behavior for another. I also had people asking about what we refer to as the social contagion effect, kind of the copycat effect, so to speak, right? There has been some indication that initial engagement in non-suicidal self-injury may be connected to seeing peers engage in this behavior, hearing about it on Facebook or Instagram or Twitter or whatever, but that the continuation of the behavior typically is more related to emotion dysregulation versus social contagion. So the social contagion aspect might trigger someone to give it a try, but that's not really connected with the ongoing problematic behavior. The ongoing behavior is the person getting something out of it in terms of helping them to manage their emotions, okay? I had questions about treatment, kind of medication and otherwise. So DBT, of course, to me is a natural, a natural choice to be a helpful treatment for this. Cognitive behavior therapy, or CBT, and mentalization-based treatments has also been used in treating self-harm, none of which have actually been shown so far to be superior than the others. Okay, so of the data that we have so far, no one therapy has found to be more efficacious than the others. And similarly, unfortunately, the evidence for psychiatric medications used in the treatment of non-suicidal self-injury is still just insufficient. So the jury's still kind of out. However, if there are underlying conditions that are contributing to the self-harming behavior, again, like a mood or anxiety disorder, an eating disorder, then of course, treating the underlying condition with medications should help with the self-harming behavior as well. So one thing that I wanted to talk about today is the origins of the theory, the biosocial theory. In DBT, we talk about the biosocial theory, which really addresses the origins of emotion dysregulation. So the idea here is that individuals develop problems managing emotions because of two main factors. The first factor is that this individual typically is more highly sensitive, is the language that I use because it's easier, and people tend to relate to being more highly sensitive more than what the actual DBT term is, emotionally vulnerable. Okay, but either way, we have this individual who has a predisposition to being more emotionally vulnerable or highly sensitive. So what that means is they react to things that others aren't reacting to. So people have a hard time understanding why there's an emotional reaction to begin with. Then the second part is if others are able to understand why there's an emotional reaction, the reaction is seen as higher than what's warranted by the situation. So this is when the teen might be referred to as overreacting, or a drama queen or drama king, those kinds of things. You'll notice the air quotes there. Please don't tell your teen that they're overreacting or that they're a drama queen or king, because that will be very invalidating typically, which we'll talk about also again today. The third part to being that more emotionally vulnerable person is that it takes the person longer to come back down to their usual self once they have had that higher reaction. And then just on a regular basis, they tend to walk around with a higher level of emotional pain. whether that's with sadness or depression, with anger, with shame, with anxiety, with a mix of all of the above, but they've just got more going on a regular basis than someone who doesn't relate to being that emotionally vulnerable or highly sensitive person. Now, we've got this highly sensitive child, we'll say. This is only part one to the theory, the biosocial theory. The and is we have that highly sensitive child growing up in an environment where they are regularly experiencing invalidation. Now, I want to preface this by saying that we are not blaming the environment, the family that's taking care of the child, the caregivers outside of the family. By and large, there's no blame to be had here. And by and large, the child or the teen is also not to blame, because we're looking at the combination of these two things over time that typically lead to the emotion dysregulation. So hopefully that will be clear as I describe this a little bit further. The invalidating environment is where the child's internal experiences, their emotions, their thoughts, their physical sensations, their internal experiences are regularly, so pervasively, judged, punished, minimized, ignored. They're somehow receiving the message from their environment that their experience is not valid, it's wrong, it's not okay in some way. Okay, now let me explain this further again, because there is a high sensitivity in the child that we're talking about here. It can often be really difficult for the family that they're growing up in to be able to understand the child's experience, especially if there aren't any other more vulnerable, emotionally vulnerable or highly sensitive people in that family. So in other words, if you have a highly sensitive child growing up in a family of non-highly sensitive people, it can be really difficult for those non-highly sensitive people to understand the experience of the highly sensitive child. And that can actually lead to just a mismatch, okay? Where, for example, the family may be trying to understand the child's experience and are kind of flabbergasted. They just can't get it. I'll describe for you one client who I saw. He was in his late 20s, I think, when I was working with him. And he described for me, his family was very loving and very supportive, and he knew that. And they struggled so much to understand his sadness as he was growing up. So he recalled his parents giving him the message, whether this was outright or more subtle. He said, I remember getting the message of, you go to a good school, you have friends, you play sports. Why are you so sad all the time? Right? And that became internalized for him. He learned to internalize that, and that message turned into, there's something wrong with me that I'm so sad all the time. I have nothing to feel sad about. He knew intellectually, and as an adult, of course, he knew that his family was not, being malicious. They were loving, they were trying to support and trying to understand. But here's where the family has to try so hard to understand, that in itself can be experienced as invalidation, where the child starts thinking, oh my God, there's something so wrong with me that my own family can't understand me. Okay, so we can have the most loving, most supportive family, and still that child that just doesn't fit in with the family for whatever reason, the invalidation can still be experienced. By the way, none of us grow up in an environment where where our experiences are always understood and accepted, which is validation, right? I remember in my own life, in my own childhood, hearing the good old, stop your crying or I'll give you something to cry about, or, you can't be hungry, you just ate, right? So these are invalidating statements. Nobody grows up in a world where your experience is always understood and accepted. And that's also not ideal, right? There's a concept of, when I have parents, I like to explain this to them when I'm working with a parent in my practice. often parents have the idea that they want to be the perfect parent, right? And of course, my first response to that is, well, what is perfect? But then also it's important to recognize that if you can be that, again, quotes, perfect parent, that often actually has negative consequences for your child, because they need to experience invalidation at times. They need to experience, problematic friendships and hurt feelings and so on, so that they can learn the emotion regulation strategies to help them manage those things. So an ideal environment isn't even where the person is validated all the time, in other words, right? The main thing that I want to get across here, though, is that it is neither the child's fault for being that more highly sensitive person, nor the environment's fault, for the most part, for being invalidating if that's how the child is experiencing it, right? It is the transactions that happen over time between the environment and the child that gradually lead to those emotion dysregulation problems. And let me also clarify, when I'm saying it's not the environment's fault for the most part, if there is physical abuse, sexual abuse, if there's severe neglect, those kinds of things, I'm not going to get too far into that, but is there a degree of blame there? There is a vicious cycle of abuse, but yes, I think that, there is some responsibility on the parents in that kind of situation when there is not a healthy environment being provided in that way, okay? Just to be clear. Now, when we have that child growing up, that highly sensitive child growing up in the environment that is pervasively invalidating or experienced as such, this is often where the child learns to invalidate themselves. So they start pushing down their emotions. And often this develops into that sense of emptiness that I'll hear clients talk about, a lack of self-awareness, not having a good sense of who they are, their identity, what their values are, and what's important to them, and so on. Also, the numbness can come from this, where people learn to stuff and push down their own emotions. Okay. Okay, so we said that. Some consequences. So what happens when we have this emotionally vulnerable child growing up in the invalidating environment also is that the child typically, because they're doing that stuffing down, they don't learn to label or trust their private experiences. So specifically their emotions I'm talking about here. And instead they start searching their environment to figure out, what should I be feeling right now? What do others want me to feel or expect me to feel? What are other people feeling, so that I can kind of fake it until I make it kind of thing. So they start scanning the environment in that way. And when I see clients who have fallen into this pattern, they've become what I refer to as the chameleon client. So they're kind of changeable depending on the situation they're in, the people that they're with, where they're looking around thinking, how do I be what's expected of me? And because of this individual the highly sensitive person growing up in the invalidating environment, they also don't learn how to manage the emotional arousal when it does happen. So when they get activated with whatever emotion, they don't learn how to manage those emotions in effective ways. They don't learn how to respond appropriately to distressing situations. And this is when the problem behaviors arise, such as the self-harming behaviors. So one thing I love about DBT is the non-pathologizing attitude, the non-judgmentalness. And so here's an example. The self-harming behavior can really usually be seen as the result of unhealthy attempts to manage emotions. And that could be any problem behavior, by the way, not just self-harm. But in other words, the child hasn't learned the healthy ways of managing emotions. And so they do learn that cutting myself or burning myself or drinking alcohol or smoking weed or whatever the problem behavior is, that helps me to manage my emotions. Numbing out with TV or with video games. So again, you can fill in the blank here with whatever the problem behavior is. But these are unhealthy ways that the child has learned to manage the emotions. By the way, as I talk about the healthy ways haven't been learned, that's also not blaming the family. If sometimes what happens is that we have a family who's trying to teach the skills, so the teaching is happening, but sometimes the learning doesn't happen. And I'll give you an example of when that might happen. Again, if we have that child who is really highly sensitive, if they're already really triggered and their emotions are already through the roof, and a parent steps in and is trying to help the child manage the emotions and is modeling emotion regulation for the child, the teaching is happening, but the learning can't happen because the child has already been hijacked by their amygdala, the good old amygdala hijack. So let me give you an example just to make that clear. If I'm 4-year-old little Sheri and I've just started junior kindergarten, and I get off the bus, my mom meets me at the bus stop on the first day of school, and she sees that I'm crying. And mom runs over to me, and I'm really distressed. I'm highly sensitive. My emotions are through the roof. Mom may be soothing me, and she pulls me into a hug, and she's stroking my hair, and she's saying soothing words, and she's saying, "Oh my goodness, you're so sad. Are you okay?" That is how children learn to soothe themselves and how to manage their own emotions, through that kind of modeling from the caregiver. But if my emotions are already through the roof, I'm not really present to take in that learning experience, okay? So even if mom is providing or dad is providing that experience, the child may not be able to absorb it and learn it, okay? Okay. So a little bit more about validation. I know this was something that I really emphasized last week, and there were some questions that came up. So let's talk a little bit more about how to do this. Validation, always remember that you get to choose what you're validating, right? You probably don't want to validate your child's choice to self-harm. You can validate, wow, you must have been so angry or so hurt or so sad or so anxious that you hurt yourself, okay? So it's two separate things: validating the behavior, validating an emotion, validating a thought. We can validate anything. And what I think the thing that we need to remember that matters the most is that validation can be very soothing. And so we do want to validate, okay? But we're probably not validating the behavior of the self-harming. What validation is about, though, is we're communicating to, sorry, this says clients, this is out of one of my workshop slides. We're communicating to the team that their responses make sense and that they're understandable. So your emotion makes sense, your thoughts make sense, your attempt at managing your emotion, maybe we could even say make sense, not necessarily the way they did it, but their desire to manage the emotion. We're also, though, so now actually there's two separate things here. Let me address this. We're communicating either understanding and or acceptance. So I can't always understand someone else's emotion. If I can't understand, I might say, it makes a lot of sense that you were this hurt. Your friends excluded you from the outing they went on or whatever, right? So I can completely understand why you would feel this way. It completely makes sense. I can't always say that, right? So even if I can't say it makes sense, we can still communicate, it's okay that you feel this way. I accept that you feel this way. I get that you're really hurt by this, right? It's okay that you feel this hurt. We don't want to discount or minimize the teen's responses. Obviously, that would be invalidation, right? So here's where we're going to break this down a little bit more and talk about some specific ways to do this. A lot of people were asking, how do I validate? Tell me more about this. So in DBT, we talk about 6 levels of validation. We can listen and observe, where we're just being with that person. We're mindfully listening to what they're saying. There might be some head nodding and some ahas in the conversation where we're actively listening, but we're just being there and letting them tell the story. That's validation. A level 2 is where we accurately reflect back to the person. So I hear you saying that you felt really excluded by your friends at school, and that's what led to the cutting. That would be accurate reflection. You're just repeating back what you're hearing. That also, by the way, allows for clarification if you've got something wrong in there. A level 3 is where we articulate something that the person isn't saying. So they're maybe not saying that they were really hurt, but you can say, you know, it seems like you were really hurt by this. Or it would make sense if you felt really hurt by this. Is that what was happening for you? So you're kind of taking making an educated guess about what the person isn't saying. We can also validate the client or the teen based on kind of what makes sense for them. So the example I've given you here is you could say to your kiddo, you know, you've learned to hurt yourself physically in order to not feel the emotional pain. So for you, it makes sense to turn to self-harming because this is how you avoid the emotions. Okay. So that's how you could validate at a level 4. It's how does this behavior make sense for this person? In other words, that's what a level 4 is. You know, for you, self-harming has become a coping mechanism. It's not healthy. We don't want it to continue, right? But you can understand why that behavior happens. Again, I wouldn't do this one too often. You probably, and you might not want to go there at all. What you can validate instead is the strong emotion that led to the self-harming, right? Validating at a level 4, if I go with the emotion, would be something like you've learned that it's scary to put yourself out there with people because you've been bullied in the past. So of course it's hard for you to make friends and you kind of hold yourself back. That would be a level 4 based on something that somebody's learned in their past that is still affecting them now. A level 5 is where we can really kind of normalize the behavior. We can say, you know, this behavior makes sense for anybody. So most human beings try to avoid pain. Of course, you don't want to feel this strong emotion. Most human beings try to avoid this amount of pain. That would be validating at a level 5 where we're just normalizing. The last way of validating is called radical genuineness. This is where, and this actually goes to a specific question that came up out of the last webinar as well. Someone actually asked, is it okay for me to tell my teen that their behavior scares me? And I thought, oh, that's radical genuineness, where you're not treating the teen as though they're fragile. You're giving them your sincere, genuine response. Okay, so a great example is exactly that. It scares me that you have to turn to self-harm to manage your emotions. Okay, so you're not treating them as fragile. You're not hiding your own emotions. It's a genuine response. And in that way, it can be very validating for the teen to have that kind of response because you're treating them as valid. Okay, almost any response can be validating from that radically genuine perspective, as long as it is still validating. It's not, you know, some kind of, you know, your sincere self might want to say, oh my God, what is wrong with you? Which would make perfect sense, but that's not going to feel so validating, even though you're not treating the teen as though they're fragile. Okay, but it still has to be some kind of validating response. Hopefully that makes sense. Okay. So a little bit more around validating. Again, we only want to validate the valid. So self-harming behavior, while we can understand it, you know, from the perspectives we've kind of talked about here, we want to more often validate the extreme emotional response rather than the problematic behavior, right? The problematic behavior, it's not helping them move towards their long-term goals. It's doing more damage than good in the long run. Well, it doesn't do any good in the short term either, but you know what I mean, hopefully. So we're only validating what is actually valid, the emotions, the thoughts, and so on. We can also actually even take that a step further and even point out how the invalid behavior is not valid, how the problematic behavior is invalid. So we can say in a non-judgmental, descriptive way, you know, I understand how hurt you were that this happened, that your friends treated you this way. And how does it help you, though, that like here you are just hurting yourself even more? So this behavior doesn't really make sense in the long run, right? We can make sense of it in the short term, although again, you probably don't want to say this to your child, but for yourself, try and understand that in the short term, the behavior does make sense because it's numbing. Remember all of those reasons that I gave you in the first session, the first webinar? It does actually help in some way. If it didn't help in some way, they wouldn't still be doing it, right? So it numbs or it distracts or it validates or it's proof of how bad they feel. Remember all of those reasons that I gave you. So when we're talking about the fact that the behavior, though, isn't valid, we just want to be descriptive and non-judgmental. Judging certainly, of course, isn't going to help. So we can validate the emotion and say, so yes, it makes perfect sense. You'd be so hurt by this. And though you're just hurting yourself more when you self-harm, and that isn't helping you move towards your long-term goals. Okay, oops, let me just get this out of the way here. Okay, so I wanted to talk a little bit also today about some of the behavioral principles that we use in DBT. I'm not going to go through all of these definitions, but I'll talk about a couple of these. It is important for us to be thinking about, are we reinforcing this behavior in some way? Now, think about, so I had one client, for example, who she wasn't 20 yet when this happened. She actually ended up in hospital after she actually went to the point of attempting suicide. And she told me after she was, the next time I saw her when she had been discharged, that her father had come to hospital to visit her after the suicide attempt. And she told me that that was the first time that she could recall that her dad had told her he loved her. Now, while there was part of me that was glad that he told her he loved her, the other part of me was going, oh no, what awful timing that it took her suicide attempt and being in hospital for dad to tell her that he loved her, because that potentially could be reinforcing of her suicide attempt. So in other words, what she may have learned there is that this is how far I have to go if I want this love and affection expressed by my dad. Okay, so I'm giving you an extreme example here. But just to help you think about, are there things potentially in your relationship with your teen, in their relationship with others? So the reinforcement might not be coming from you. It could be coming from anywhere in the environment, but it's an important question to be asking ourselves. Are we somehow providing reinforcers to this behavior where we're keeping it going? Okay, so I'm not going to go through positive and negative reinforcement, intermittent reinforcement. Actually, I am just going to pause on intermittent just to say that intermittent reinforcement is when the reinforcer only happens occasionally. And so if you think of the gambler as kind of the textbook example here, the person pulling the slot machine arm, right? And every once in a while they get that win, and that's what keeps them going back. Intermittent reinforcement is one of the most successful ways of reinforcing a behavior. And so this is why consistency is so important. You do not want to only occasionally reinforce the person's behavior. Okay, or let me rephrase that. Actually, that kind of came out wrong. You don't want to occasionally give in and reinforce the teen's behavior when they've self-harmed, because that is going to be really a strong reinforcer and keep the behavior going, okay? So you want to be really consistent, have the same negative consequences consistently when there's been that problem behavior. Okay, in terms of consequences, of course, this one's pretty straightforward. It's the outcome of something that occurred earlier. So what happened after the self-harming behavior, right? That's all that a consequence is. They can be positive or negative. And so this is something that's important for us to be looking at. If there are positive consequences, they could be reinforcing and keeping the behavior going. We can also help people move away from self-harming behavior by shaping behavior. So for me, when I'm working with someone who's self-harming, sometimes we'll get them to do things like slapping an elastic band really hard on their wrist or holding an ice cube in their hand. So yes, both of those techniques still involve pain to manage emotions. And so no, in the long run, they're not ideal solutions, but they are a step in the right direction. In my mind, holding an ice cube until your hand hurts is much better than taking a razor blade and cutting yourself. Or even I've had a client who had the elastic band on her wrist and she slapped it so hard and so often that she had a big red welt around her wrist. But even that is much less, it's the level of lethality is completely different, right, than someone who's taking a knife or scissors or a razor or whatever it is and cutting. So no, it's not ideal, but it's a step in the right direction. So that's what shaping would be, where we get those baby steps happening and gradually we move in the direction that we want the person to go in. And also modeling, we can be thinking about how can we demonstrate a behavior that we want the person to be doing more of themselves. And the main example I use here is validation. Remember, often that highly sensitive child growing up in that invalidating environment, they turn the invalidation inward. So they judge themselves, they judge their feelings, they push down, they avoid, they ignore, and that contributes a lot to the emotion dysregulation. So a big skill that we work on in DBT is helping the person to validate themselves. Okay, so this is just kind of a summary in terms of behavior theory. We need to be considering, is there some kind of reinforcement that's keeping the behavior going? And how can we then change that? Are there negative consequences or punishers that are preventing or kind of suppressing the more positive or even just neutral behaviors that we want? And how can we shape or model those positive behaviors and the healthier behaviors, right? So that the teen is going to start to engage in those behaviors all on their own. Okay, so a couple of questions that came up. What if your child tells you that they don't want to stop cutting? So I was thinking about this from a behavioral perspective, and I thought, well, if the child doesn't want to stop cutting, I mean, there's lots of ideas that would come up skill-wise here, but thinking about from a parent's perspective, dealing with the child, I mean, you can get into a really big power struggle here, right? Obviously, you want them to stop. If they're saying, no, I don't want to do that, what do you do? Well, you can think about the consequences. What are the logical consequences of the behavior that they're engaging in? If they cut, then they're not going to be able to go out with their friends afterwards because clearly they're not in a safe place, right? So that would be, I'm just throwing out examples here. I'm not telling you what to do with your kids specifically, right? But that may be a logical consequence. Or it's a logical consequence as well that they can't have access to razor blades alone if they cut themselves in the shower. So all of the razor blades have to get out of the bathroom and they have to be supervised when they're shaving their legs or their face or whatever, right? If being alone is a trigger for cutting, so if there's a pattern of the self-harming behavior when they're by themselves, then it would be a logical consequence that they can't be left alone for long periods of time. So even if the child is saying, I'm not willing to get help, I don't want to stop, thinking about the behavior from this behavioral perspective can help you potentially to shape some changes, to get some changes happening in the long run, just by how you're responding to those behaviors. Somebody else had asked, should you hide all of the sharps in your house? And I mean, this is a good thought. I said, well, maybe but is this really realistic? I mean, don't you need kitchen knives at times? And, where do you keep all of the sharps in your house? And can you really find all of the sharps in your house? If your child really wants to cut themselves or do some kind of self-harming damage, they're going to find ways to do it. I've had clients who just severely scratch themselves. And that's enough to, create infection or other problems. Again, the level of lethality is completely different. But I think that if they really want to engage in that behavior, we can't prevent them from finding something to do that with. So, and I said, if it is realistic or possible to hide all of the sharps, will they find other ways of self-harming? However, I think this would be a good conversation to have with your child. Is this something, again, this would be more along the lines of a teen who is wanting help or is, agreeable to talking about it. Do you think, we could hide all of the sharps in the house? Would that help you to move away from this behavior and get their input on it? Remember, guys, so much of this is about communication with your teen. So, when people ask me, how do I support my teen through this? My response is always going to be, have you asked them that question? Like it's something that's going to be different for everyone. So the dialogue has to happen between you and your teen. I also had somebody who sent in a lovely example or a lovely statement about their own lived experience. And they said that as someone who was diagnosed with BPD as an adult, I did engage in self-injurious behavior as a teen, but only on a few occasions. And she said, I had never seen or heard of anyone doing this and wondered why I did this without ever hearing about it. So to go back to that social contagion effect, sometimes it's just something that people start on their own as a behavior. She said, I do recall being overwhelmed with emotion and preferred hurting myself over others. So she saw this as a way of, if I hurt myself, then I won't externalize the anger or, whatever that the emotion was. And as a mom of a loved one who has been self-harm free for a year, and congratulations, by the way, if you're here, focus on the relationship with your loved one. Find a way to connect, communicate, and meet them where they are. It's so hard being a parent. You're not alone. I thought that was lovely. I put a few resources here together for you because people were also asking, where do you look for more help with this? So my book was published last year, the DBT Skills Workbook for Teen Self-Harm. Sheri Manning wrote the book Loving Someone with BPD back in 2011, and it's still one of my favorite books, not just for BPD, just emotion dysregulation in general, and it takes a very DBT perspective. There's also a great book if you are dealing with BPD specifically in your family or loved ones, Mindfulness for Borderline Personality Disorder. And to help with those behavioral concepts that I was talking about earlier, there's a really great book called Don't Shoot the Dog. Karen, I believe is her first name, Pryor, the author, she is an animal trainer, and she talks about these concepts that are well known in the animal kingdom and training animals, but applying those behavioral concepts to relationships and humans. So that might be a helpful resource for you as well. Okay, guys, so that is the end of the webinar, and we do still have about 10 minutes for questions.
Great. Thank you, Sheri, so much once again. Yes, we have lots of questions, and I know we'll receive more over the next few minutes. I'm going to start with something that came up a couple times last time as well, and we didn't really address it. Eating disorders are diagnostically different from self-harm. Can you help us understand why an eating disorder is not simply perceived as being a type of self-harm?
Yeah, I mean, it is certainly, and this, I did talk about this last time in the sense of self-harming versus, so non-suicidal self-injury. This is why we use that term specifically, right? Rather than self-harming. An eating disorder can easily be seen as self-harm, but it is not non-suicidal self-injury, which is where we're inflicting tissue damage. We're inflicting damage on the body. Okay. So when we talk generally about self-harm, we could also say, substance use is self-harming, or, there's a lot of different things that we could refer to as self-harming. But NSSI is a very specific, the inflicting of damage on the body. So then someone might say, well, someone with an eating disorder, they know that their bulimia, for example, is doing damage to their heart. So isn't that still non-suicidal self-injury? But that's not the intention, right? The intention is about weight. It's about body image. The intention with non-suicidal self-injury is to inflict damage on the body. Does that help, Doreen?
Yeah, it does. Thank you. That's great. Then the next question that came in, and I'm sure others will wonder this as well, was about social media. So you spoke about how social contagion might make somebody want to try out self-harming. But it's not likely to, really encourage them to continue it. But what about social media, specifically where somebody might find a lot more acceptance or, they don't feel so alone. They feel really understood by their involvement in social media. And could that help to perpetuate it and continue it?
So the research has shown, I can only tell you what the studies have shown us, which is that it does seem to contribute to the trying it out, but it doesn't really influence if they keep going. Now, do people, once they have tried it out and it does something for them, they realize that it does help manage emotions, do they then get involved in the social media? Absolutely. I would say more than likely, although I haven't seen the research on it, but I would say for sure, just my gut instinct would say yes. But the research shows us that it's not, the social contagion effect isn't contributing really to keeping the behavior going.
So they try it, and either they find it to be effective for their emotional challenges, or they don't find it effective. And that's really where the decision point comes in for them.
Yeah. Okay. And this actually is a good example. So I wasn't going to go into the negative reinforcement, but this is, I think, actually quite pertinent here. Negative reinforcement is when we remove something that is aversive. And it is a strong means of keeping a behavior going. So if you think of self-harming as negatively reinforcing, where it takes away the painful emotion, that's how it is negatively reinforcing. And so that usually is one of the bigger components with self-harming in terms of how it helps as an emotion regulator, so to speak.
Right.
Yeah.
Okay. I remember having a conversation with a friend when our kids were both young teens, and I knew my kid was self-harming, cutting, and I knew it was helping them, right?
Yeah.
In that maladaptive way. And this friend said, oh yeah, my kid came home from school and said everybody else at school was cutting. And so she tried it. And the mom asked, well, did it make you feel better? And the kid said, no, not going to do that again.
Exactly. Right.
And I was like, okay, our two kids are obviously very different because they did the same thing and had a completely different reaction and response to it.
Exactly.
Great. Thank you. Okay. The next question that came up is more about the family constellation. So a lot of people are maybe struggling with this concept of validation, or, maybe you and your spouse, both parents, are not on the same page around how to approach an issue. So maybe you could speak to that a little bit. Also, the other piece that came up is maybe if you're in a family situation where it's both your partner and your child who both have emotion dysregulation issues, and you're kind of feeling a little caught and not sure, where do you put your attention and where do you focus the validation to help?
Gosh, I mean,
like that triangle.
Yeah, I mean, when I have a teen where there is difficulties in communicating, and where I'm seeing that maybe there's some deficits in validation, like validation doesn't seem to be happening enough in the home, what I'll actually do is I'll bring in, one or both of the parents, preferably both of the parents if they're both involved, and especially if they're all living in the same house together still. And I'll actually encourage a team effort. So I'll actually teach the biosocial theory as I taught it here, so that everybody understands, it's not any one individual's fault. It's the interactions that have been happening here. And we need to get those interactions happening differently. So now then I teach validation while everybody's in the same room together with me. And we get it to be a team effort where parents have to validate the kid and kiddo has to validate the parents. And it becomes a project, right?
Right.
So that's probably what I would suggest there. Now, I mean, of course, it's going to be harder for the more highly sensitive people who get to that high reactivity level. It's going to be harder for those folks to do the same levels of validation, right? It's going to be harder for them to validate others if they're already through the roof with emotion, right? But validation is what brings the emotion down. Validation is what is soothing, that gets us back down to the state where we're more able to reconnect. And so if you're that unfortunate person where you're the non-highly sensitive person living in a household of other people who are more highly sensitive, so everybody around you is losing their shit, then unfortunately it might fall to you to do a little bit extra validation so that you can get others to practice coming down with you. I mean, there's other skills that I would, if this was a client, I would be saying, do the tip skill together or forward bend together, so there's lots of other DBT skills that might come into play there also. Mm-hmm. But validation, I really think of validation as a superpower though. If you can get it going, there's a really nice YouTube video. It's about 4 minutes long by Dan Siegel called Name It to Tame It. And if you haven't seen that, it's a really nice, just quick video on how validating someone else helps to soothe the emotion, how it tames the emotion for them. So that can maybe speak a little bit more to that as well.
Okay, great. Thank you. That's a great tip. Yeah, we got a lot of questions about validation. I'm going to put a plug in here for everybody out there. If you have not yet attended Family Connections, please go to the Sashbear website and get your name on the wait list to take Family Connections, because a lot of what Sheri talked about today is part of the Family Connections program. And we cover validation, we cover the biosocial theory, and a lot of other communication strategies. And so, some of this stuff you will actually get an opportunity to sort of practice and discuss further if you are able to attend one of the programs. But a couple of specific questions that came up. One was around this idea of, radical genuineness. Oh my gosh, that's so scary to me when you self-harm. The question came up, what if that makes your child feel guilty, you sharing your emotions, and then they carry some guilt? Is that a problem or a consequence?
I don't see it as a problem. I see it as a logical consequence, a natural consequence, right? This goes back to one thing that we hopefully are trying to teach our kids, but something that I often am trying to teach my clients is that we're not responsible for other people's emotions, right? We're not blaming them for making us feel anxious. It's a natural response, and I'm sharing with you how I feel. So no, I don't see it as problematic. If anything, also, sometimes the emotional response from the people around them will actually serve as a negative consequence for the self-harming behavior that will help them to work on eliminating the behavior. In other words, it does act as a deterrent if there are negative responses from the environment.
Okay. Great, thank you. Another question around validating and actually invalidating. Somebody would like to hear maybe some examples of invalidating things you might say to a child who's self-harming that are really problematic. Things that a parent might say with the best of intentions.
With the best of intentions. I mean, I'm not sure about best of intentions, but I think just in a dysregulated way ourselves, right? When we're, freaking out because we've just found out that our child is self-harming. Oh my God, what the hell are you doing to yourself? What are you thinking? Are you crazy? Like, why would you do something like this? So I think as a parent, that would probably be my gut response, my gut reaction So not necessarily with the best of intentions, but with really, just our emotion mind taking over, I would say, right? So, judgmentalness, just those kinds of things.
Right. Just that natural being
The
human.
natural
Parents
response.
are people
like,
too.
what the hell is happening? Yes. So.
Right. Okay, great. Thank you. And then I'm going to loop back to the biosocial theory and this concept of the invalidating environment, because there were a couple things that came up there. One was around if a kid happens to be questioning their gender identity or their sexuality, is that something that might sort of invite some more invalidation, or they might experience invalidation, and it could play into the development of emotion dysregulation and maybe self-harm?
I would think so. Yeah. I mean, my understanding from clients nowadays is that typically their peers are quite accepting of differences in gender identity and sexuality and so on. It's the older generations, whether that's their parents or other family members or, other adults in their life or whatever, that tend to be, not necessarily judgmental, but more maybe judgmental, more invalidating, even worried for them. Well, I'm worried, what is this going to mean for you, the pressures that you'll face and so on, right? So, I mean, and I think that can be invalidating, or they can experience invalidation in a lot of ways that way. So I would think that would be probably just one of many things that they might experience invalidation about, but definitely, I think it's a contributor. And actually, even as I'm saying that, I am recalling a study that showed that teens who do identify as LGBTQ plus are at higher risk of self-harm. So I think that statistic would also speak to that.
And then I guess bringing in some dialectical thinking, that might not be the only thing that's going on,
sure.
Right?
Yeah.
There could also be other issues underlying as well.
For sure.
Right? Okay. And another piece here was a question around intergenerational trauma, and whether, could you just sort of speak generally about the impact that might have on development of emotion dysregulation in terms of family history or perpetuation of?
That's a good question. I don't feel like I really can speak very well to that. I mean, I think to me, that's one that's going to really depend on the context. I certainly think it would contribute. And just for people that don't know maybe what intergenerational trauma is, think, for example, the Indigenous schools, right? That's been so, in the news and so horrible, all of the news coming out of that recently. The trauma that gets passed down from generation to generation. To me, that would be less about the family and more about probably, the oppression that's been experienced by the family through the generations. But that's why I think it would really depend on that individual's experience, because, you could have someone who identifies or who is Native Canadian, who has grown up in a very Caucasian culture and doesn't really relate to their Native Canadian heritage. And so they might not have any intergenerational trauma like that. So I think we would want to look at it through that individual's lens. But I can't really speak much more to it other than that. Yes, I would imagine it would have an effect, and we would have to look at that each individual's experience in order to help them to make sense of their experience and how that played a role.
Okay, great. Thank you.
Okay.
I'm just scrolling through the ones that we have here. Some of the answers, I believe, will be addressed if people go back and rewatch, maybe, or if they watch your previous presentation as well, hopefully, because I know you've covered quite a lot. One question I think we really should address is when do you treat it as being a suicide attempt and make that choice to call 911? Is there ever a time when you would look at it that way?
Yeah, I mean, so I actually hear two different questions in there. When do you treat it as a suicide attempt, and when do you call 911, right? Okay. Like, you're going to call 911 or take the child to the hospital when it's clear that this is beyond just a scratch on the arm when it needs medical attention, in other words, right? I wouldn't necessarily be, especially if this is a pattern of behavior. We know that often hospitalization is not very helpful. And in fact, when BPD is a diagnosis, it's actually counterproductive for the individual. So hospital ideally isn't, happening on a regular basis. It can be very reinforcing. And I'm not going to get too far into that, but when the child needs medical attention, especially if it's early days of self-harming, like if it's a first self-harm kind of thing, and it's, uncertain whether it's a medical need or not, you might just err on the side of caution to have it looked at, right? When do you treat it as a suicide attempt? When the individual indicates that it was a suicide attempt, essentially, is how I would answer that. I always ask my client, when you cut yourself, did you mean to, when I'm first getting to know this person and this is a new behavior, when you do self-harm, is it meant to, like, what is the purpose of the self-harming? This is how I'm having the dialogue with my client. Why do you do it? Help me understand. What's the purpose of it? Were you trying to kill yourself? Or, were you trying to not feel something? So just trying to understand it from their perspective. If it was a clear suicide attempt is what I want to say there, but that's not helpful. If someone, let me just make this up, if someone took a knife to their throat and dug in pretty hard, that's probably not just self-harm, even if they insist that it was, so unless it's something really clear like that, then I would be going with what they tell me. So again, it's about communicating and asking those questions.
All right. And that validation is about building up the relationship to a point where you can have that conversation, right? Okay.
Yeah.
Great. Thank you so much. I think we need to draw it to a close here. Sheri has been very gracious with sharing her time with us. I want to thank you all for having been here. And just remind you once again, this has been recorded and we will be posting it on our website and on our YouTube channel, sashbear.org. We are a charity and we welcome donations to help make these services available to you. Sheri has also graciously agreed to distribute the slides. So if you would like to receive a copy of the slides from today's presentation, you can email us and Barb will put the links and all of that information into the chat. The email is programadmin@sashbear.org, and you can email us to get a copy of the slides for today. The first part, the first presentation that Sheri did was recorded and is already available for you to watch. This one will be posted again for you to watch again if you happen to come in late or if you want to watch it again. And we have some guests lined up. In April, we will have a presentation with Dr. Francesca Paraplechkova, and she is also going to be speaking about validation and invalidation and sort of the development piece of how that affects someone's development. So please look forward to that. We'll have Dr. Blaise Aguirre and Dr. Gillian Galen joining us again in the summer. And once again, our Sashbear Walk will be coming up in May. So look for more information about that. Thank you, Sheri, so much for having been with us once again. This was absolutely fabulous. And I know you've helped many, many families out there understand this issue better.
Pleasure. Yeah. Thanks everyone for being here. Take care.
Good night, everyone.